And then TMJ, the ability to look at your condylar heads, again, from the axial, from the top down, from the sagittal, from the side, from the coronal, and look at that symmetry and get an idea of what's going on, both with the patient in occlusion, articulated, and then if they have an appliance, with the appliance in, to see that, to see the comparison. It's incredibly powerful for TMJ treatment, and we can actually compare the two. We can compare the divergence of angles, we can see if there's any pathology, any resorption, any remodeling, and then we can compare them. And this is really powerful, anybody who does TMJ treatment. The ability to see the articulation. And again, looking from the side, sagittally, to see when we're articulated versus an occlusion, how we come out of the fossa, how far it goes. Looking at this from the top, there's the condyle closed, open, see how it just moves forward. So the ability to see that, and to see the range of motion is powerful, especially when it's not symmetric, when it's asymmetric, and you see one side's locked. Something like this. Open and closed, it's not moving. And that tells a huge, huge story. In addition, for anybody doing TMJ, and then I'll get back into CT in the sweet spot, but if you're doing TMJ work, also look at the upper cervical. You've captured it. Take a look. Because what you'll see is when you have TMJ problems, because the musculature connects, very frequently your atlas and axis will be yanked out of whack. And you'll see patients with neck pain. They'll have neck pains, of course. They're clenching, they're bruxing, they've got TMJ problems, they can't find a comfortable centric. And it's causing neck pain. It's being reinforced by this asymmetry. And so you will see that more often than not. And take a look. I mean, you've already got the information there, so that you're able to really tell. And then, of course, the axis, that's going up into your magnum foramen, big hole in the base of your skull. And what else is sitting up there but your brainstem? So to have that now asymmetrically pushing against your brainstem, that can start to mess with autonomic functions like digestion. It really is well connected and pretty well documented. We do a lot of CEs ourselves. They're free. We have a TMJ series. Not that I'm pushing that. I'm just saying if you want to learn more. But there's a lot out there that shows this connection, and it's interesting to see. So if you're ever treated TMJ repeatedly and you just can't quite get it, take a look and see if that axis is off those occipits. And that, more often than not, that can solve the problem. So that's the non-implant side of CT. To get to the implant planning, which is really where CT shines, and it shines for good reasons and bad reasons. Implants are really great, they're really scary, right? This is the only scary part of the program, besides that last slide. But anyone know who Art Curley is? Yeah. I like it when rooms say no. That's always a good sign. Art is the defender of doctors. He does malpractice just for dentists. And he wrote 6 years ago. He actually wrote and said it's almost malpractice to do implants in your practice without offering today's available technology, including 3D imaging. I've had the privilege of lecturing with Art twice, with Art, and I've been to a couple of his seminars in addition. And there was one where Art was next to, you know, the legal equivalent of Art, the Darth Vader? Anyone run into Ed Zimmerman? So Ed, nice guy. I can't say a bad thing about him. Nice guy. He was a periodontist and then went to law school, and he tends to represent patients in malpractice claims. And so you love to see this guy. You're a little more scared of Ed. And 4 years ago, wrote in CDA, he says, hey, CBCT technology has transitioned to a standard of care for dental practices for diagnosing and managing some conditions. No one's going to say you have to use it. It's not the law. But the law is whatever is the standard. And the standard is whatever is known and easily accessible. So, you know, if CTs were just in Alaska, not really the standard. But these two both agree that when you have a CT for implants, you're pretty well covered. When you don't, you're pretty well not. And that's the, I actually have an entire legal sheet. We have a table back of an entire legal sheet talking about all the lawyers and what they say. But it's not a bad idea just to evaluate what's going on. End of our scary part. We'll go to the fun part of implant planning. So with implants, normally what you'll see, the CT cross-sections, you'll get back a bunch of CT images. And if folks are nice, like me, I'll measure them for you, or you can measure them yourselves. You can get an idea of how much room you have at different angles. And what I do, and what I think you should ask for if you're sitting somewhere, is I'll measure what is the minimum, at what point are we at least 5 millimeters wide? Because if you have 20 millimeters of bone until you hit the nerve or sinus, 20 is probably not realistic, but if you have a sizable distance, but the ridge comes to an apex, you're not going to place an implant right up to that point. Right? You need a certain width. So we'll measure down to the minimum. We think 5 is a good number. So really we're saying you've got to reduce 9.5 millimeters until you get to this minimum width, and then you've got an ocean of bone. But just be prepared, there's a lot of reduction going on until you hit that spot. And you may not know that just looking. So you can measure, and this is basic implant planning. It's not rocket science, it's pretty easy. You're using CT, different perspective. But can true measurements lie? And this isn't a trick question. This is actually what I think is the most important thing I'm going to say. Is, can measurements lie? And this measurement, maybe you place it this way. So instead of 10.5, maybe you have a little bit more. But that's only one angle. That's like looking at me and saying, hey, Marshall's leaning to the side, and now I'm not. But if I start leaning forward, I start leaning at an angle, you're only seeing this on one plane. So what is really being measured here? And this is really important to understanding CT. Let's say you're being responsible, you're using CTs, you're ordering these, you're doing your treatment planning, but can you still be off? And the answer is yes, unless you know what you're doing or you know what to ask for, and then you get it. But I'm going to ask a question, how far do we have from the top of the ridge to the nerve canal, from top to bottom? How much room do I have? And I'm going to argue that the yellow line is a different length than the red line. That's a pretty easy argument. Yellow's vertical, the red's angled. So how are these CT slices made? How did I make that slice for you? Well, we start off at the midline, and then we start with parallel slices going back a millimeter, and they slowly go back. Right? That's how slices are made. We see them all the way back. 2 light bulbs just went off. This is the part I love. So that I'm overcaffeinated. So right, if we're placing implants here and here, this is your slice. That's when you get to measure. But is that really the angle you're placing the implant? You have a curve of speed. Jaw's not flat. The world's not flat. I learned that with my whole Greenland thing. Your face isn't flat. You learned that with panos distorting 25%. Your jaw's not even flat, unless you're Jay Leno. And so you start curving back. So all of a sudden, these parallel slices, they're good. They're better than nothing. You can definitely see any defects, especially lingual defects or internal defects. You won't have that hidden marble in the brick anymore. But you don't know how much room you have. And so when you see this measurement, which one is it? Is it the yellow or is it the red? And that can be a really important question based on the angle the patient was scanned in the machine, their curve of speed and the slope. All of a sudden, it's an extremely important question. And let's say, looking at this case, we have a couple different implant angles that are divergent. And let's say we're going to extract and put another implant here. All of a sudden, the difference between this parallel slice and the relevant angle is pretty huge. We're back to pano accuracy. Even though you sent out for a CT, you did what was right. You were afraid of Darth Vader and Ed Zimmerman. And you said, I'm going to do the CT thing. I'm going to measure this. I've got 12 millimeters. Great. Going to go to ankylose. I'm going to get a 10 millimeter implant. I'll have 2 millimeter till a nerve canal. And you've got 9. Because you're not placing the implant tilted back. You're placing it at the curve of speed. So what's the solution? And by the way, just to totally give credit where it's due, for the first year and a half of Reveal, I didn't have a solution. I actually was looking for one. We were trying to triangulate, basically to advanced geometry, saying, well, here's what it really should be, because our software, we can't angle the whole thing. We got our care screen and we could. You can change at each implant site. You can tilt your software to figure it out. And if you buy software, other parties, your Anatomages, your Simplants, your SciCats, your Cybermeds, your InteGuides. I know this because we own them all. We've been on just like CTs, we're on a software shopping spree. But you can do that with third-party software. But if you're just ordering out a CT, or you're just hitting the button and seeing what comes out on your own CT, make sure you know what you're doing here. Because you want that angle. You want to know that difference. It could be slight. It could not be. So right here, we're angled. This is back to implants. We're angled. And look how this changes. These are millimeter slices. Look at the difference in just 4 millimeters of what we've got to deal with. And you may not get that from the PA. But now you're at the correct angle, you've got your relevant measurements. It really, really gets a lot easier. Maybe not surgery, but it sure gets a lot easier knowing what's going on. So that's the implant planning side. We're looking at CTs. Again, I have to keep this up to keep me focused. Now we're into guided surgery. And I label this guided surgery. It's really guided surgery software. It doesn't have to be guided. There's different ways to do surgery. You can do eyes and odds, which is where you say, hey, I've got 2 eyeballs, I know my odds, it looks pretty good, I'm going to go for it. And that's how 95% of implants are placed in America. Actually, probably even a little bit more. So yeah, so 19 out of 20 are placed on eyeballs. Hey, but if you have this amount of podium, an ocean of bone, and you can see it, your odds are pretty good. You've got your CT, you know there's nothing going on inside, you've got no odd concavities, no defects. Why not? So there's that. There's DIY, do-it-yourself. And these are self-made ones. These aren't bad. It's better than nothing for tricky situations. And there's a company called AZ Surgical, founded by a surgeon in Mountain View. And they make these little things called Easy Stents, 30 bucks each. That's all they cost. You throw them in hot water, this acrylic heats up, you put it over a model, you angle it how you think it should go, you drill a hole, this cools, and you've got yourself a guide. And hey, for 30 bucks, it's something, right? You can have your lab make one for you. Then there's computer generated. This is, if I pejoratively could say the real guides, but you've got computer made. point is, I always say, check out what you're doing first, and then decide afterwards. If you've got the ocean of bone, you might not even need a guide. And even for myself, for my family, if I had a really large dentures area, tons of bone, maybe I'd say skip the guide. If Chris was doing it, I would. So, you've got different options.